Hello everyone, today I'm going to talk about thyroid disorders. As you know, thyroid is present in the neck, like it is a butterfly shaped organ. It has two lobes, right and left. So what we see is that this is the isthmus, this is the right and left lobes. You know that the thyroidectomy is a very crucial procedure because the procedure may involve injuring the vocal cord. So that's the reason why the recurrent laryngeal nerve has to be spared. So if not, the patient may lose his voice. This is a normal thyroid gland. You know that the inferior and superior thyroid artery are the arterial supply of this thyroid gland, right? So this is a normal histology of the thyroid. That is, it is having cuboidal cells, okay, and it is in the form of, all the cells are in the form of follicles. They contain large amount of colloid. As you know that the amount of thyroid secreted is depending upon the TSH that is released from the pituitary, and the amount of TSH released from the pituitary is also regulated by the thyrotropin releasing hormone, which is released from the hypothalamus. This is all something you know, it is physiology of the thyroid hormone. So this is hypothalamus releasing the TRH, pituitary releasing TSH, and then there is a release of T3 and T4. As you know that the steps of formation of triiodothyroxine and tetraiodothyroxine, I think you all know about it. I'll just give you a recap of it. It is just that the iodine has to be trapped in the thyroid gland. This is the trapping, that's the first step involved in the formation of thyroid. Then the second step is that it has to be oxidized. So there is an oxidation of the iodine which is happening, and after that the iodine molecule is taken up by the tyrosine. Tyrosine, as you know, is an amino acid. It will form monoiodotyrosine or diiodotyrosine. This formation is called as organification. Once the monoiodotyrosine is combined with diiodotyrosine, it forms T3, okay, and then the two diiodotyrosine, when they combine together, they form the T4, right? So this is the formation of the thing. And once this organification happens, it will be released. How it is released? In the blood, it is bound to transthyretin, albumin, and thyroid binding globulin. Okay, and this released hormone is stored in the form of colloid. So we have seen that there is this colloid. These are the cuboidal cells, and this is the colloid, right? So in the form of colloid, the hormones are stored. Okay. And there are some other cells called parafollicular cells or C cells, other than these cuboidal cells which are lining this follicle. So they secrete the calcitonin, which is essential in the calcium metabolism. Okay. So this iodine trapping, organification, that is not oxidation but the organification, all steps are dependent upon the release of the TSH. So once there is decreased amount of TSH, the T3, T4 levels are not absolutely reaching the body's requirement. So there is an imbalance. Okay, as you know that the thyroid is an essential component. What are the thyroid functions? Thyroid maintains the metabolism of the body. That is, the cell growth and regulation is maintained. The vitamins and hormonal function is maintained. That is the rate of release. It is almost like a time clock. Okay, you have to eat. You have some work. Then what do? You eat in 15-20 minutes and then you get back to your work. But if your thyroid is low, what do? You do things slowly. Okay, so you have a sluggish movement in your life. The same way that happens to each and every cell of our body to make things slow. Okay, the production of extracellular matrix, everything will be altered. So that's the reason why the thyroid is such an essential hormone. It is also important that the tyrosine is the amino acid which is present, has to be in normal amounts, and as you know that it is the iodine which is getting oxidized and helping in the formation of thyroid. The iodine deficiency also may lead to abnormal thyroid disorders. So the thyroid disorders may be related to absolutely the hypothalamus disorders directly, which release the TRH, or the pituitary disorders. Okay, as you know, the anterior pituitary is responsible for the TSH secretion. Okay, so the anterior pituitary disorders and the thyroid disorders itself, something like a carcinoma, thyroiditis, which will have direct effect on the release of the thyroxine hormone, or if there is a binding problem, that is the transport is dependent upon albumin, thyroid binding globulin and transthyretin. When there is this problem, that is all, if the albumin is low, if there is not adequate thyroid binding globulin, or the thyroid binding globulin is already filled up and it is having some antibody to the thyroid binding globulin, okay, then what will happen? There is a thyroid disorder. So once you know the physiology of what is happening, then you know that this disorder is because of this, right? So as is the disorders of thyroid or hyperthyroidism, that is increase in the thyroid level, the T3, T4, hypothyroidism, decreased T3, T4, thyroiditis, that is itis means inflammation, so there is inflammation of the thyroid gland, diffuse and multinodular goiter. Once the thyroid, I told you, has two lobes and isthmus, right? So once this lobes and isthmus become multiple they form the multiple nodules, then it is called as multinodular goiter. Okay, then the neoplasms, adenoma or carcinoma. The benign counterpart is the adenoma or the carcinoma. Congenital malformations include the formation of thyroglossal duct cyst, right? So this has to be differentiated from the brachial cyst, which occurs laterally, and the thyroglossal cyst, which occurs in the midline. And then once you see the patient coming and you ask him to protrude the tongue, once you ask him to protrude the tongue like this, there is a movement of the thyroid gland here. Then we know that this is the duct cyst, absolutely by the clinical definition itself. Then you can do an FNAC from the duct cyst, and then you can go for the surgery. Right, so these are the disorders of the thyroid. So coming to the hyperthyroidism. Hyperthyroidism, as I told you, what are the functions of the thyroid? It is trying to maintain the metabolism. Okay, it is having receptors in the nerves, and that's the reason why once there is hyperthyroidism, there is increase in the increased reflexes, and then there is increased what you call sympathetic activity. And also we are talking about the metabolism, that is a hypermetabolic state. What happens when you are having hypermetabolic state? You want to drink more, you want to eat more. Okay, you have irregular heartbeat. For everything you get anxious, then you kind of have palpitations and all. Okay, and more metabolism is happening so that your body doesn't put on good amount of fat and then you look lean. So that is about the hyperthyroid features, what happens, that is clinical symptoms related to increased thyroid hormone caused by elevating levels of free T3 and free T4. Once I talk about free T3 and free T4, that means that these are the thyroid hormones which are not bound to the albumin or thyroid binding globulin, right? Usually the thyroid binding globulin has 1/3 occupied by T4 itself. Okay. So what happens whenever there is an elevated circulating levels of free T3, free T4, that is the T3, T4 which is detached from the thyroid binding globulin, right? So it causes hyperfunctioning of the thyroid. So either it is by oversupply, that is the thyroid is very active in producing lot of hormones, or it is by excessive release. Excessive release is by thyroiditis or inflammation or an extra thyroid source. That is, see something like struma ovary, you find the thyroid situated in the ovary, right? So in those kind of conditions, you see some abnormality related to this. Then what are the types of hyperthyroidism? It arises from intrinsic thyroid abnormality, it is primary. Secondary, it is from the process, that is TRH, TSH level, I told you. Either it has to be inside the gland itself or it has to be from above the brain, that is the pituitary or the hypothalamus. So hyperthyroidism conditions. What are the conditions where there can be T3 and T4 are toxic multinodular goiter, toxic adenoma, thyroiditis, functioning thyroid carcinoma. So the thyroid carcinoma can be functioning and may not be functioning. Functioning means the thyroid function is to release hormones, right? So when this happens, it is called as functioning thyroid carcinoma. If it's not happening, it is called as just the thyroid carcinoma, right? TSH secreting pituitary adenoma. Pituitary adenoma can be of various types, wherein each hormone is anterior pituitary and posterior pituitary. You know that oxytocin and vasopressin are released by posterior pituitary. Anterior pituitary, the growth hormone, TSH, FN, all these things are released. So this TSH, if only that is, those cells are forming an adenoma in the pituitary, then there can be hyperthyroidism. Okay, so disorders associated with thyrotoxicosis are the primary diffuse toxic hyperplasia, that is Graves, that is the most common, that is primary, 85%, hyperfunctioning toxic MNG. We're talking about this. The neonatal thyrotoxicosis associated with maternal Graves. Whenever the mother is having a Graves disease, then the baby also acquires the thyroid hormones. That's the reason why in the gestational period you have to see that the thyroid hormone is not above 3.5 or not below 0.05. Okay, so that's the target you have to reach. Usually they say that if you're maintaining a level of 2, it is absolutely fine, because you are not making the person go into hypermetabolic state or into a hypometabolic state. The secondary is TSH secreting pituitary adenoma, which is right. So what are the features? I told you there will be hair loss, okay, and then anxiety, exophthalmos because the muscles and extracellular matrix is getting deposited in the eye. So that's the reason why there is protrusion of the eye, laxity of the muscles, so that is causing exophthalmos. Lid retraction, lid lag is the same cause. Then goiter, what you see in the neck. Then in the heart, there is tachycardia, palpitation, atrial fibrillation. Atrial fibrillation is irregular rhythm of the heart. The rhythm of the heart is not maintained. And extreme weight loss will be there. The person will be lean, thin. There is menorrhagia, diarrhea, warm, moist palms, tremor, onycholysis, acropathy, that is related to the fingers and the nails. Then pretibial myxedema, that is the extracellular matrix deposition happening in the tissue before the tibia, that is causing the pretibial myxedema. Proximal myopathy related to the muscles. Osteoporosis, because I told you that the thyroid hormone is essential for regulation of all the hormones and the vitamins in the body, essential for the absorption, growth, and regulation. See, once a patient is having low thyroid hormone, then the patient may have anxiety related to the psychology, or he may have a low mood, a depressed mood, something like that. Okay. So all the hormones in your body will be affected. So there is some other term called apathetic hyperthyroidism. This refers to thyrotoxicosis in the elderly. Usually we don't find any kind of features of those excess thyroid hormones like hair loss, anxiety, palpitations, all these things. But sometimes you ask them to get a lab work done, and then they get that done, and you find that the T3, T4 levels are pretty high. So that's how you diagnose apathetic hyperthyroidism. Okay, now coming to the main disorder related to the primary hyperthyroidism, that is Graves. This is a common cause of the hyperthyroidism, as I told you. Females 20 to 40 years are affected. It is usually autoimmune and autoimmune. What I mean by autoimmune, identification of the self antigen as foreign and then producing antibodies to it, right? You will find that usually whenever the bacteria and virus come from outside, that is identified by our antibody as foreign, and then the NHC will act, and when they will recognize that it is a foreign particle, then it will bind to it and then form antibody or phagocyte, right? So we have different ways of complement activating system which will help in the inflammation and then finally death of the foreign particle. But what happens here is that there is some sort of imbalance happening, that is recognition of the self antigen as foreign, and then there is production of antibody. So there is no self tolerance. So that is autoimmunity. The triad of clinical features include hyperthyroidism, increased T3, T4, exophthalmos, protrusion of the eye, pretibial myxedema. These are the three features of the Graves. That is, there are many features, but these include the triad. So there is diffuse enlargement of the thyroid, infiltrative ophthalmopathy with resultant exophthalmos, localized infiltrative dermatopathy called pretibial myxedema. It is just a synonyms which I have given here. It is also called infiltrative ophthalmopathy, and then there is this localized infiltrative dermatopathy. Okay, so the genetic factors are important. It's more seen in monozygotic twins and as high as 60% associated with HLA haplotypes, HLA, B8, 7 and DR3 polymorphisms in cytotoxic T lymphocyte 4 gene. So what happens when there is a polymorphism in the cytotoxic T cells? The cytotoxic T cells will be kind of having the cell mediated death, right? So that's the reason why this is important. So what is the pathogenesis? I told you that it is about autoimmunity. So autoimmunity, there should be some antibody which is formed recognizing the self-antigen. So the antigen is what we'll see here. Antibodies to the TSH receptor, to the thyroid peroxisomes, and to the thyroglobulin. So we told you that the thyroglobulin is essentially the colloid material which is present, and peroxisomes, I told you that they help in the oxidation of the iodine. The TSH receptor, say once the TSH is formed in the pituitary, it is released in response to the amount of T3, T4 identified by the body. Okay, so there is a feedback mechanism. Once the T3, T4 are low, then the pituitary identifies this. There is a feedback mechanism happening. The pituitary will start secreting more TSH. Okay, so in the same way, if T3, T4 are high, what happens? There is this TSH which is trying to be low, right? Because there is no activity of TSH here. But here in Graves, what is happening? The TSH is produced. That TSH which is produced is trying to act on the thyroid receptor, TSH receptor that is present in the thyroid gland, and still it is not able to function. That means, for example, this room is a thyroid. If somebody from outside knocks the door, that is a TSH. What happens? It keeps knocking, but the TSH receptor, the door is not opening. So what happens? The TSH is unable to do its function or communicate with the person like me who is sitting in this room called thyroid, right? You got it? So that is what is happening. So there is antibody to TSH receptor which is there. So the TSH receptor is not opening door for the thyroid stimulating hormone to act. There is no feedback mechanism is happening, or there is this thyroid peroxisomes which are required in the oxidation, and that is the antibodies are going and stopping that, or to the thyroid globulin. Okay, so for this what you do is, there is something called TSA, that is thyroid stimulating immunoglobulin, what you call, that levels can be checked. Okay, and LATs, it stimulates thyroid hormone. Slowly the TSH and mimics the action of TSH with increased release of thyroid hormones. So either the thyroid hormone is directly released, or the regulatory mechanisms are stopped because the TSH, everything is not able to act properly. And the antibodies are coming and sitting and throwing their arms on this peroxisomes and thyroglobulin, they are not able to act. Okay. So now Graves' ophthalmopathy, what is it? So the volume of the retroorbital connective tissue and the extraocular muscle is increased owing to what? Infiltration of the mononuclear cells, inflammatory edema, accumulation of extracellular matrix, increased number of adipocytes, and that's the reason why the eyeball is displaced forwards. So you know that the thyroid is a regulatory hormone, right? So in the same way, it is related to the extracellular matrix deposition. I told you this. So once this is not happening properly, there is accumulation of extracellular matrix. So because of that, there is laxity. Edema is present because there is infiltration of the mononuclear cells owing to autoimmunity. Increased number of adipocytes, then eyeball is displaced forwards. So I told you that there is this antibody to what? Thyroid stimulating immunoglobulin, thyroid growth stimulating immunoglobulin, TSH binding inhibitor immunoglobulin. So we got to know that there are some antibodies to the TSH receptor, peroxisomes, and thyroglobulin, right? In the antibodies to TSH receptor, there are these three types in that. That is the thyroid stimulating immunoglobulin, thyroid growth stimulating immunoglobulin, and TSH binding inhibitor immunoglobulin. So, in the thyroid, what we see grossly is that there is symmetrical glandular enlargement because of increased functioning. Diffuse hypertrophy, obviously cells are actively participating in the functioning of secretion of the thyroid. Then hyperplasia, tall columnar cells and papillary folds. This hypertrophy and hyperplasia, that is increased hypertrophy is increased size. Hyperplasia is increased number. So the increased cell size, the increased number of cells, both will cause papillary folds because they want to just accumulate, in the same place. So there is scalloped or scanticolored. Everything which is produced is just going out. So there is no proper storage. So scalloped, scanticolored. Extrathyroid tissue involvement will cause generalized lymphoid hyperplasia. Okay, there can be hypertrophied heart with ischemic changes, edematous orbit. I told you that it is called as infiltrative ophthalmopathy. Infiltrative dermatopathy, that is thickening of dermis because of increased extracellular matrix. How do you diagnose this? Decreased TSH, obviously there is no work for TSH at all when the thyroid itself is trying to produce T3, T4. Radioactive iodine can show diffuse uptake indicating a thyroid storm. Graves' disease can be a medical emergency in patients with increased catecholamines because I told you the thyroid hormone has its functioning ending in the nerves, which are the sympathetic system. So usually the person who is having hyperthyroid symptoms will have increased sympathetic activity, and because of that there can be palpitations and irregular heartbeat, everything else. So that will hamper the normal metabolism, normal functioning of the individual. So what is thyroid storm? Thyroid storm is encountered during infection, surgery, cessation of antithyroid medication, or from any stress. So what is happening? You are giving some antithyroid medication. You don't want these thyroids to function so much. We want just balance in life, right? So once you kind of stop these antithyroid medications, then there can be a thyroid storm. Patients are febrile, there is no fever, but present with tachycardia out of proportion to the fever. So the patients during infection or surgery may present with fever, and then these patients will have out of proportion of tachycardia. Usually the heart rate is more in fever, right? So the temperature is more, the heart rate is usually, the pulse is more than normal. So out of proportion of the fever means the if you are anticipating at the level of 100 degrees centigrade, you are anticipating heartbeat of 80 or 90, then it is usually 100 or more. Then it is called as thyroid storm. So this is a gross picture you see. The diffuse enlargement, this is a cut section actually. Here you can see that this is the diffuse enlargement of the thyroid gland. Here you can see the papillary folds. Papillary means finger-like projections. So you are seeing lot of papillary folds here. Okay, you can see here all these are the papillary folds. Okay, and there is scalloping of the colon which is present. So as we finish the major part of the hyperthyroidism, contributed by 85% of the individuals having hyperthyroidism having Graves' disease, we now come to something called as hypothyroidism, that is decreased T3 T4. It is called as cretism or myxedema. Cretism usually in the children units we call that. And then myxedema, it is usually the low T3 T4 and high TSH. That means the thyroid is unable to produce the T3 T4, but the TSH, the pituitary function is normal and it is trying to push the thyroid. Come on, you do it. Come on, secrete more. You know, something like that. So what is happening here? There is Hashimotos thyroiditis. What are the things which cause TSH increases? Hashimotos is autoimmune again. So there is something identifies as self-antigen for which the antibody is produced. Iodine deficiency, as you know that iodine is essential for the oxidation, right? So once the oxidation does not happen, the organification is not happening sufficiently, so this will cause the TSH increase. The drugs like PM-N-salicylic acid, iodates and lithium. The developmental, that is the atrophy, hypoplasia, pituitary disorders, post-ablative radiation surgery, radioiodine therapy, congenital biocentric defect, that is dysharmonogenic goiter. See, once there is a, what do you mean by a biosynthetic defect is that, see, you know such conditions like alkaptonuria and like, you know, those storage disorders like galactosemia, all these things. So there is some enzyme or some molecule which has to be produced for at the biochemical level, at the cellular level to the normal functioning of the hormone, right? So once there is a biosynthetic defect, then what happens? There is some congenital biosynthetic defect. Then there is not, the production is not happening properly. So that is absolutely called as dysharmonogenic goiter, right? This primary we have talked about, and now secondary hypothyroidism caused by TSH deficiency, frequently due to pituitary tumor, postpartum pituitary necrosis. See, once there is postpartum, there are some conditions called as Sheehan's and all of that, which can cause the pituitary necrosis, and this will cause no TSH, no pituitary function, so no thyroid formation. Trauma, some non-pituitary tumors which can inhibit the normal functioning of the thyroid. So tertiary hypothyroidism, usually we call this as central hypothyroidism caused by TRH, that is thyrotropin releasing hormone deficiency, that is from the hypothalamus. This can result from tumors, trauma, infectious disease and radiation given for certain other causes. So this is thyroid atrophy. See, what happens when some tissue in our body is not functioning or not used, then it calls atrophy. They think that, okay, I'm not used, so what is the purpose of me? Even your brain, if you're using it continuously to be active, there is a saying that the puzzles or the Sudoku solving people won't have memory deficiencies or Alzheimer-like disorders because you are exercising your brain continuously. As you exercise your body, the same way you have to exercise your brain. In the same way, thyroid thinks that, okay, I'm not used, or I'm just lazy now, I don't want to produce any thyroid hormone. So that's the reason why it thinks that it is inefficient. So what happens to that kind of a tissue? It goes atrophy. Then what are the features? Here we see the first thing opposite to the hypothyroidism, weight gain, menorrhagia there. Here menstrual irregularities will be there. So some people will have excess, but some people will have very, very low menses. Then constipation, there we are saying diarrhea. Here constipation. Carpal tunnel syndrome, we saw that there is some association of the nails and fingers because of the extracellular matrix deposition. Here we see the carpal tunnel syndrome. Dry skin and cold skin prone to hypothermia. Hypothermia is the temperature setting. Usually the thyroid hormones is very essential for the metabolism. That's the reason why cellular regulation, but also the temperature maintenance. Diminished sweating. In hyperthyroidism, we are finding excessive sweating, cold palms, cold clammy palms, like slowing of activity, bradycardia, ischemic heart changes. There we are finding atrial fibrillation, anxiety, and we also see palpitations. Okay, so gruff voice. Okay, there is a kind of voice, that bass wala voice. So there is psychosis, loss of outer third of the eyebrows, that is only medial part of the eyebrows is present and lateral part, this part is lost. And then the slow cerebration, or sometimes there will, the patient, you ask some question and then there will be blank. They have to actually kind of stimulate their brain and ask again, or they'll ask you again, just what did you say? They'll ask something like that. So dry hair. Okay. So this hypothyroidism in child and in adult. In adult, we're calling it as myxedema, cretinism in child. So the impaired CNS development and bone growth, mental retardation, short stature, coarse facial features, protruding tongue, umbilical hernia. These define the cretin child. And here in the myxedema, we have slow physical mental activity, cold intolerance. Usually in hyperthyroidism, we find heat intolerance. Here in hypo, we find cold intolerance, overweight, low cardiac output, cool pale thick skin, constipation, decreased sweating. See, cretinism, if you want to remember this movie by Vishwanath Garu, that is the Swati Mutya movie, In that what happens? The person, usually the cretin is something related to a term where it is the Christ-like. Christ-like means they are so innocent or so good that they can't do a sin, So cretinism defines impaired CNS development and bone growth, mental retardation will be there, but they're not sinners. They'll be very afraid to do sinful activities. So that's the reason why cretin is Christ-like. Okay. Okay, this is what I've told you. Incapable of sinning. The term cretin derived from Christian or Christ. Normally, the maternal hormones cross the placenta are critical to fetal brain development. So that's the reason we've had to maintain the gestational thyroid level at 2 usually, and better below 3. Each gestation is having variable levels of the thyroid hormone which have to be maintained each trimester, So that has to be followed, regulated in that way. Otherwise, the person may have some disorder. It is not taken care. Usually nowadays that hypothyroidism is very, very common. Almost like 90% of the women are having hypothyroidism, and every 80 to 85% of women are having the polycystic ovarian disease and all because of the stressful life they have. So having thyroid in deficiency is not the problem, but you have to take care and regulate and increase your metabolism by doing exercise and all. So once you do that, you are pregnant and you maintain your thyroid hormones level regularly, then there is no absolute problem. There are children who are having very good activity and no thyroid abnormality because though the mother has a thyroid abnormality because of the maintenance or regulation of the thyroid by the mother in the gestational period, right? So reduction in maternal thyroid hormone later in pregnancy allows normal brain development. So myxedema, the adult or the dull disease. Initial symptoms, fatigue, mental sluggishness, I told you shortness of breath, reduced cardiac output. Okay, there is, what is happening here? There is accumulation of matrix substances like glycosaminoglycans, hyaluronic acid in skin, subcutaneous tissue and visceral cell, leading to edema, causing features, stiffening voice, enlargement of the tongue. Okay, so extracellular matrix deposition. Then diagnosis, serum TSH is low. TSH can be high in primary hypothyroidism. T4 is low in all patients. So what we see is primary, secondary, again, central, tertiary. Three types of hypothyroidism we talked about, and we also talked about myxedema, the adult disease, and the cretinism seen in the children, right? So we are to differentiate in the laboratory diagnosis. We are finding TSH high in primary hypothyroidism and decrease in T3, T4 levels. In the secondary hypothyroidism, we may not find the TSH as high as the primary hypothyroidism, and then the T3, T4 are as usual low. Okay. Now coming to the topic called as thyroiditis. We saw hypothyroidism, hypothyroidism, okay, primary, secondary areas, and then we come to the inflammation of the thyroid gland. The inflammation can be bacterial, viral, or fungal disease manifested by pain, tenderness, and fever, autoimmune thyroiditis. The same way like Graves and the hypothyroidism caused by the autoimmune activity, there is something called as Hashimotos thyroiditis. Granulomatous thyroiditis, it is not having a definite cause. Radius thyroiditis is a fibrosing thyroiditis where the normal follicular structures are atrophied, and then what happens is that there is all fibers, the fibrous stroma that is being excessively produced, replacing the normal thyroid tissue. That can mimic a carcinoma because it is having a very stony hard consistency. So the thyroiditis as such, like any other organ, can be caused by any microorganism, autoimmune disease, granulomatous, and radius or fibrosis. So it is associated with pain or dysfunction, that is painless. So in with pain, we can have infectious subacute granulomatous. With dysfunction of painless, we have subacute lymphocytic thyroiditis and fibrous thyroiditis. So coming to the infectious, can be acute or chronic. You know the meaning of acute or chronic, right? So there is pain in the gland, there is fever with chills, function alteration is very minimal, and it is heals with less residual effects and scar. It is not showing any abnormality, any high abnormality as such like the primary hypothyroidism or hypothyroidism. This shows abnormality in the levels which is just transient. In 1 week or 2 weeks, the patient will have normal thyroid levels. So pathogenesis, whenever there is a microorganism, there is cellular humor-mediated injury that is happening to the thyroid follicles. The cell-mediated injury, you know that it is T-cell mediated. And the humoral, the B cells which form the antibodies can be against what? Thyroglobulin, TSH receptor, against iodine transporter, other antibody against the cell membrane, the microsome. See, for what antibody, what is something just you have to remember. There is no way out. This was just a concept. So the thyroglobulin, TSH receptor, iodine transporter, and against the cell membrane in the microsomes, you can have antibodies. CD8 cells, toxic to the, so stromal lymphomatosa, epidemiology studies have demonstrated significant genetic component, 30 to 60%, unlike mostly 60% in the Graves. In Turner syndrome, also they have anti-thyroid antibodies, 20% of them develop hypothyroidism, and also Downs. The pathogenesis, There is progressive depletion of thyroid epithelial cells, which are replaced gradually by the mononuclear cells, and there is fibrosis. Sensitivity of this CD4 plus T helper cells to thyroid antigen appear to be the initiating event. So the effector mechanisms are CD8 plus, interferon gamma, antibody dependent cell mediated cytotoxicity. So what is happening here? The CD4 plus T cells initially recognize an antigen, and then they will start the autoreactivity, that is to the thyroid antigen itself. That is something like an autoimmunity. Then what happens? There is depletion. It is going on, killing everybody in the line. Okay, so thyroid follicular cells are replaced by the mononuclear cells or the inflammatory cells, and it forms a fibrosis. This is also helped by CD8 cells, interferon gamma, and ADCC. Right? Now coming to Hashimoto's. It is very common, non-endemic. Endemic means in a certain place the disease exists continuously or it is persistent. Non-endemic goiter means it's not persistent but it is present. That is seen in females 45 to 65 years. HLA DR5, DR3, the thyroid antibodies to anti-thyroglobulin is firm, diffuse goiter just like that of the Graves, but there is a bit of whitening or paling, what you see here in the gross. There is follicular atrophy because the thyroid cells are being lost, and there is mononuclear activity in form of lymphocytes. There are Hürthle cells, eosinophilic epithelial cells. Hürthle cells are nothing but the cells, the thyroid cells, which transform themselves to be Hürthle cells with abundant eosinophilic cytoplasm in the nucleus, which is pushed to one side, is having vesicular nucleus. Okay, this is about the Hürthle cell. Initially in Hashimoto's, there can be hyperthyroidism. In Hashimoto's, thyroiditis can be a precursor for B-cell lymphoma. Morphology, I told you, it is pale grey tan color. That is very important distinction between the Hashimoto's. In the size, you know, the Graves, you can see a large size. Here we can see 100 to 300 grams only. And there is a fleshy appearance. Fleshy appearance, something like lymph node. We'll think that did I cut a lymph node or a thyroid? You know, something like that. So this is the Hashimoto's thyroiditis you're seeing. Diffuse enlargement, the right lobe and the left lobe. Here in the microscopy, you see extensive mononuclear infiltration with lymphocytes, plasma cells. There can be lymphoid follicles which are forming just like that of the lymph node, having a prominent germinal center. Small atrophic follicles will be there. That is a thyroid follicle. They decrease in number. They are degenerated. The large cells with the cytoplasm, if at all we see, are the Hürthle cells. Increase in fibrosis will be there. And there is another counterpart, subset of this Hashimoto's thyroiditis, which is called as atrophic type. That is a fibrous type where there is more fibrous tissue, less mononuclear infiltration, and less gland cells. So what do you see here? In the gross, we are seeing the right lobe and left lobe, diffuse enlargement, and pale grey tan appearance resembling a lymphoid tissue. In the microscopy, we see prominent, the initial site, we see very less number of the thyroid follicular cells. Okay. Sometimes we see this destruction of the thyroid follicular cells. That means the follicle should be round, right? Once there is destruction, you see the mononuclear cells coming inside like this. There is an opening here. Okay. And then there is a lymphoid follicle formation with a prominent germinal center. Okay. And there can be Hürthle cells. Hürthle cells are these cells. See here, you can see the abundant eosinophilic cytoplasm. See these are cells, and the vesicular nucleus. This is the vesicular nucleus. And all these cells are Hürthle cells, and these are the reactive lymphocytes. Okay, so there is atrophy of normal thyroid follicular cells, mononuclear cell infiltration with prominent germinal center, and here we find abundant eosinophilic cytoplasm in vesicular nucleus to one side, that is the Hürthle cell. Clinical features: painless enlargement of the thyroid, middle-aged woman will be affected. There is symmetrical enlargement, then the transient hyperthyroidism due to destruction of the follicles followed by gradual hypothyroidism. So there is something called as Hashimotosis, that is hyperthyroidism in pre-existing Hashimotos, that is hypothyroidism. Families with coexistent Hashi and Graves within the affected kindreds are seen in the patients presenting with the Hashimotosis. That means one person in the family having Graves, one person having Hashimotos, and their progeny may have this kind of Hashimotosis. Again, there is a fibrous variant where there is keloid-like fibrosis, which does not extend beyond the capsule. So I'll just stop here. We will see the subacute thyroiditis and the Riedl's thyroiditis in the next class, along with the goiter, that is the multinodular goiter and the toxic adenoma, and the other benign cancerous counterparts in the next class. Thank you.